Um, Good morning. My name is Genesis Vigipur Arechua. My student number is S327028, and this is my presentation for the Communication and Interpersonal Skills model at the University of Suffolk. Today, I'll be analyzing the strengths and limitations of a particular communication style, passive communication. I'll also explore how it appears in health and social care settings with a specific focus on dementia care. Let's start by looking why I choose this topic. In dementia care, many staff members cares naturally adopt a soft and more passive communication style. This is often because they want to avoid upsetting someone who may feel anxious, distressed, or confused. Although this comes from a good place, it can sometimes mean that the person's own voice is not fully heard. For the next few minutes, I'll explain uh, what passive communications look like, discuss both strengths and limitations, and examine how it affects person-centered care planning and teamwork. This presentation These presentations link with the three learning outcomes. Learning outcome 2, adapting verbal and non-verbal communications to different situations. Learning outcome 3, using communications to develop person-centered care plans. And learning outcome 5, collaborating effectively with others. And finally, I'll provide some practical recommendations for improvement. So, what is passive communication? Passive communications is a style in which a person avoid openly express their feelings, opinions, and needs. Instead, they tend to prioritize other people's preference, often to avoid conflict. The common signs include soft or his state speech, included limited or eye contact, and close or without postures. Researchers such as Agli identify these nonverbal cues as an important part of how communications is interpreted. People who communicate passively often find it difficult to say no, apologize frequently, and allow others make two decisions for them. It is useful to think that communications as a continuum. At one end is passive communications, in the middle is assertive communication, and at the opposite is aggressive communication. Passive aggressive communication can be viewed as a related but no more direct style. Recognizing where behavior sits on this continuum help us to understand what passivity can be helpful and when it might become a problematic. Passive communications is not entirely negative. In fact, it offers several important strengths with care settings. Firstly, it can reduce conflict and confrontations. This can be particularly helpful when supporting a person living with dementia who is feeling anxious or agitated. Secondly, passive communication is often slower and gentle in its approach. This can help us to build trust with someone who feels scared, confused, or disorientated. Another strength is that passive communications often listen more than they speak. Careful, careful listening is central to what Kit would describe as a positive person work, which focus on recognizing and validating the individuals rather than directing them. Finally, during a highly emotional situation such as end of life care, creating a space and allowing someone to express themselves can sometimes be more therapeutic than taking highly assertive approach. Therefore, in the right circumstance, passive communications can be generally accepted. However, passive communication also have a significant limitations. When passivity becomes habitual, important need and concerns might remain unspoken. For example, if a care worker does not raise concerns about pain, distress, or a safety issue, those concerns might go unaddressed. Passive communication can also contribute to what is known as elder speak. This is an overly soft and infantilizing communication style. Researchers by William Kemper and Humbert found that elder speak can actually increase resistance to care among people living with dementia rather than reduce it. At organization level, passive communications can weaken the wide safety culture. Research constantly showed that staff who withhold their voice are less likely to report mistake or raise concerns before they become serious. At a more fundamental level, he would warn that behavior associated with what he called malignant social psychology includes talking over people, talking down them, and this can undermine person's dignity and sense of personhood. This is an important implications for people-centered care planning. Effective person-centered care depends on the staff finding out what matters to them, to the individual, and responding to those needs rather than assuming they already know. A passive care work may simply agree with what colleague or family member believes is best, instead of checking directly with the resident about their own preference. As a result, the care plan may become less individualized. For example, imagine a resident who regularly resists being washed in the morning. A passive work might choose record that resistance and move on, rather than exploring the reasons behind it. As a result, they may fail recognizing an unmet need such as uh, pain, fear, or anxiety, or simply choose a preference for watching later in the day. Truly person-centered practice requires to initiate these conversations and explore the concerns assertively rather than the simply following the path of the last resistance. So when is passive communication effective and when it does it become problematic? It can work well during calm and hurrying situations. For example, when sitting quietly with someone receiving end of life care, allowing periods of comfortable silence, or giving a person enough time to process the information without feeling rushed. However, passive communications become more challenging in situations that require clarity, confidence, and timely action. Example includes multidisciplinary teams meetings where concerns need to be raised directly, safeguarding situations that requires immediately reporting, care plan reviews where residents' wishes need to be represented clearly, and discussions involving medications and pain management. Research on patient safety highlights an important point. Remind silence in these situations can be dangerous because the consequence of not speaking up may be far greater than temporary discomfort of doing so. Passive communication also influences how effectively teams work together. Successful multidisciplinary teams depends on everyone sharing information clearly and consistently. Communications tools such as SBAR were developed specifically support in this process. However, a team member who communicates passivity with unholding important observations about resistance changing conditions. This can weaken shared decisions making across the entire team. This chart, funding from 2024 nursing study, Nurses who reported withholding their voice rated acclimate approximately 2.8 out of 5. In comparison, the most assertive group rated at 3.1 out of 5. This finding suggests that the speak up and maintains a positive teamwork climate reinforce one another. This finding suggests that speaking up and maintaining a positive teamwork climate reinforce one another. On a personal level, I think it is important to reflect on whether I sometimes agree with a senior colleague rather than raising concern. If that becomes an habit, I could limit how effectively I contribute to shared goals and decisions making. So, how can someone with passive communications style improve without losing the warmth to make decision effective? Firstly, structures assertive training can help. One example is the DES framework, which involves describing situations, expressing feelings, suggest solutions, and starting consequences. Systematic reviews have shown that this approach can improve healthcare professionals' confidence when speaking up. Secondly, reflective training can reduce elder speak. The changing talk or chat programs successfully reduce patronizing communications in nursing home and also reduce resident resistance to care. Thirdly, structured communications tools such as SBAR provide a clear and low-risk framework for raising concern. This can be particularly helpful for people who are naturally quieter and less confident. Finally, creating a psychological safety culture is just as important as developing individuals' communication skills. Supportive team make it more easier for quieter staff member to contribute their view and raising concern when it's necessary. To conclude, passive communications brings genuine value to dementia care. Its gentlest patience and calm presence can help resource people who feel anxious, scared, or confused. However, when passive communications become the default approach, it can silence the individual's voice, weaken person-centered care planning, and negatively affect both safety and teamwork. Moving towards a more assertive style while maintaining warmth and empathy better supports the three learning outcomes discussed in these presentations. Adapting communications to the situations, developing person-centered care plans, and collaborating effectively as part of a team. For my future practice, my goal is to use the DES framework the next time I need to raise a concern rather than allowing to remain unspoken. Thank you for your listening.